Hey everyone, before we dive in, do 3 quick things that really help us. Subscribe to the channel, like this episode, and drop your next topic request in the comments. Done? Great, let's get started. Welcome to episode 1 of our case-based scenarios series. Today we will untangle common exam scenarios around malaria and dengue, highlight the urban nature of certain vectors, and pin down what the India's National Centre for Vector-Borne Diseases Control, formerly the National Vector-Borne Disease Control Program, actually recommends right now. Dr. Joshi, thanks for joining us.
Happy to be here. Quick orientation. In India, the National Centre for Vector-Borne Diseases Control, under the Ministry of Health and Family Welfare, administers the umbrella National Vector-Borne Diseases Control Program for malaria, dengue, chikungunya, Japanese encephalitis, kala azar, and lymphatic filariasis. Knowing the official names and their latest guidance impresses examiners and keeps practice current.
Let's start with scenario 1. A 28-year-old man in the OPD has high-grade fever with chills and severe retro-orbital pain. What's your provisional diagnosis, key case management steps, and community interventions per the national program?
Severe retro-orbital pain with an acute febrile illness immediately raises dengue on the differential. Malaria with chills and rigor is also plausible, so the provisional diagnosis is acute undifferentiated fever, dengue versus malaria, with dengue more likely on history. First, case management at the facility. Apply the National Centre for Vector-Borne Diseases Control's 2023 National Guidelines for Clinical Management of Dengue Fever. Triage by severity. Group A, outpatient. Group B, warning signs. Group C, severe dengue. Warning signs include abdominal pain, persistent vomiting, mucosal bleed, lethargy or restlessness, liver enlargement, and rising hematocrit with falling platelets. Avoid non-steroidal anti-inflammatory drugs, use paracetamol and meticulous oral or intravenous fluids guided by vital signs and hematocrit, and reserve platelet transfusion for clinically significant bleeding or specific coagulopathy, not merely for low counts. For diagnostics, do a rapid malaria test and smear, plus dengue NS1 antigen in the first 5 days or dengue IgM afterward, because missing malaria is dangerous, and early dengue confirmation refines fluid therapy. If he's Group A, manages outpatient with strict return precautions and daily review. Groups B and C need monitored care with protocolized fluid resuscitation. Community interventions follow the umbrella program: immediate case notification, fever surveillance in the neighborhood, and integrated vector management, source reduction, anti-larval measures, and space spraying fogging only as an outbreak containment adjunct. Education on dry day practices, that is, empty, scrub, cover containers weekly, and enforcement at high-risk premises are emphasized by the program's dengue materials. Pause and recall. Which lab test is most useful in the first 5 days of suspected dengue? Answer: NS1 antigen.
Nice. Scenario 2. A 30-year-old laborer has had 4 days of high-grade fever, weakness, anorexia, and a rash since this morning. There's water accumulation at his construction site and several colleagues are ill. What's most probable and what prevention control measures, especially environmental, should be described?
The cluster, construction site, water accumulation, and rash strongly suggest dengue. Aedes aegypti, the dengue vector, is a deer-biting domesticated mosquito that breeds in man-made containers, exactly what you see at urban construction sites. The national portal explicitly lists Aedes feeding in domestic and peri-domestic settings and its container breeding ecology. Environmental management is the backbone. 1. Eliminate source of breeding. Drain, empty, cover or discard water-holding containers, drums, tins, tires, plastic sheets. Maintain weekly dry day with scrubbing to remove eggs. Secure overhead tanks with tight lids. Ensure proper side drainage. 2. Anti-larval measures. Temifos in potable water where appropriate. Use larvivorous fish for large clean water bodies. And environmental sanitation to prevent water stagnation. 3. Organizational measures. Mapping of case residences and work sites, house-to-house search for fever cases, entomological indices monitoring, and targeted space spraying around active transmission foci. These are all embedded within program guidelines and state dengue action plans under the national umbrella. Pause and recall. Which comes first during an urban dengue surge, fogging or source reduction? Answer: source reduction. Fogging is adjunctive for adult knockdown around case clusters.
Scenario 3. A 25-year-old male has high-grade fever with chills and rigors. Peripheral smear is positive for Plasmodium vivax. What is the treatment protocol and what are the general recommendations for malaria management under the national program?
For confirmed Plasmodium vivax malaria in India, the National Malaria Drug Policy has long recommended chloroquine in a total dose of 25 mg per kg over 3 days for blood stage clearance, plus Primaquine 0.25 mg per kg daily for 14 days for radical cure of liver hypnozoids. Before prescribing the 14-day Primaquine, assess the risk of glucose 6-phosphate dehydrogenase deficiency. Primaquine is contraindicated in pregnancy, infancy or known G6PD deficiency and should be stopped if hemoglobinuria or cyanosis develops. This remains the standard in program documents and is consistent with recent Indian scholarship and WHO positions, even as research explores shorter Primaquine regimens. Apply this clinically. A 25-year-old with Vivax gets weight-based chloroquine for 3 days plus 14 days of Primaquine after G6PD consideration, counseling on adherence, and follow-up to ensure apyrexia and smear negativity. Pause and recall. What is the purpose of the 14-day Primaquine in Vivax? That is, radical cure, prevention of relapses from dormant liver stages.
Final scenario. An epidemiological assessment claims that dengue is an urban disease. Justify and list urban prevention control measures.
The statement is broadly justified by vector ecology and epidemiology. Aedes aegypti is highly adapted to urban habitats. It breeds in artificial containers, bites during the day, prefers human blood, and thrives with high human density and mobility. Features of towns and cities. The national dengue pages call out its domestic and peri-domestic feeding and breeding behavior, while global evidence links urbanization rates with dengue incidence. That is why dengue and Japanese encephalitis are flagged as outbreak-prone and climate-sensitive conditions under the national umbrella. Urban prevention and control exam style should be written as 1. Environmental management where weekly source reduction, that is dry day, container management in households, schools, hospitals, markets and work sites, cover overhead tanks, fix leaking taps, improve solid waste management so containers do not accumulate water. 2. Anti-larval measures where Temiphos in potable water were indicated, biological control with Lavivorous Kish in large water bodies, and community education on safe storage. 3. Adult mosquito control where focal space spraying around reported cases and clusters as a short-term measure, timed to the day-biting behavior of Aedes. Case vignette tie-in, at construction sites, store materials undercover, drain basements and lift wells after rains, provide a sump pump after rains, assign a supervisor for weekly container inspection, and maintain a log that municipal inspectors can verify. That is exactly how you cut the urban chain of transmission.
Before we wrap, can you give students a quick comparison checklist, malaria versus dengue, for exam answers?
Sure. Fast recall. Fever pattern, both can be high-grade. Periodicity favors malaria but not reliable early. Pain, severe retro-orbital pain and myalgia point to dengue. Lab, malaria confirmed by smear or rapid diagnostic tests. Dengue by NS1 in days 1 to 5 or IgM later. Management, malaria species-specific antimalarials. Dengue, no antivirals, fluid-guided care and no routine platelet transfusions. Pause and evaluate. If you had to prioritize one community action this week in a dengue-prone ward, what would it be? Answer, door-to-door source reduction with behavior change communication, then focal fogging around clusters.
Perfect. Today we covered provisional diagnosis and management of febrile cases with epidemiological clues, the environmental backbone of dengue prevention in cities, current Vivax treatment under the national program, and why dengue is called an urban disease. Big thanks, Dr. Joshi.
Thank you. Keep revising the official NCVBDC guidance, especially the 2023 Dengue Clinical Management Guidelines and the 2023 to 2027 Malaria Elimination Strategy. Those are high yield for exams and for practice.
If you found this useful, remember, subscribe, like, and tell us what topic you want next. See you in the next episode.